Adrenal incidentaloma, investigations and management. An adrenal incidentaloma is an adrenal mass discovered incidentally during imaging for unrelated reasons. These lesions are often asymptomatic but require thorough evaluation to determine their functional status and malignancy risk. Investigations. 1. Clinical assessment. History. Symptoms suggestive of hormone excess, e.g., weight gain, hypertension, fatigue, virilization. This family or personal history of cancer or genetic syndromes, e.g., MEN2, Li-Fraumeni syndrome. Physical examination, signs of Cushing syndrome, hyperaldosteronism, or virilization. 2. Biochemical evaluation, assess hormonal functionality. 1. Cortisol secretion, low-dose dexamethasone suppression test, administer 1 mg dexamethasone at 11 p.m. Measure serum cortisol the next morning. Interpretation, cortisol, 1.8 micrograms per liters, indicates autonomous cortisol secretion. 2. Catecholamine secretion, measure plasma or urinary metanephrines and normetanephrines. Interpretation, elevated levels suggest pheochromocytoma. 3. Aldosterone secretion, if hypertensive or hypokalemic. Measure plasma aldosterone concentration, pH, and plasma renin activity, PRA. Calculate aldosterone to renin ratio, ARR. Interpretation, high ARR suggests primary aldosteronism. 4. Androgen secretion. In virilized women, check DHEAS, testosterone, and 17-hydroxyprogesterone levels. 3. Imaging studies. 1. Computed tomography CT. Evaluate size, shape, and density. Key features. Size. 4 cm raises concern for malignancy. Hounsfield units HU. 10 HU suggests lipid-rich benign adenoma. 20 HU raises suspicion of malignancy or pheochromocytoma. 2. Magnetic resonance imaging, MRI, preferred for indeterminate lesions on CT. Loss of signal on chemical shift imaging indicates lipid-rich adenoma. 3. Positron emission tomography, PET, 18F FDG PET for differentiating malignant from benign lesions. Hot 4. Biopsy. Indications, only if metastasis is suspected and functional workup is negative. Contraindications, pheochromocytoma, risk of hypertensive crisis. Management, 1. Functional tumors. 1. Cushing syndrome. Surgical adrenalectomy, usually unilateral. Postoperative glucocorticoid replacement may be necessary. 2. Pheochromocytoma, preoperative alpha-adrenergic blockade followed by beta blockade. Surgical resection. 3. Primary aldosteronism, adrenalectomy for unilateral disease. Medical management, e.g. mineralocorticoid receptor antagonists for bilateral disease. 4. Androgen-secreting tumors, adrenalectomy for virilization. 2. Non-functional tumors. 1. Size-based approach of 4 centimeters. Observe if imaging features suggest benignity. Repeat imaging at 6 to 12 months. Borgie 4 centimeters or suspicious imaging features, consider surgical resection. 2. Growth on follow-up. Rapid growth, 1 centimeters per year, may indicate malignancy. 3. Malignant tumors. Primary adrenal cancer. Complete surgical resection with negative margins, open adrenalectomy. Adjuvant mitotain therapy or chemotherapy for advanced cases. Metastatic tumors. Manage based on the primary cancer. 4. Follow-up. Periodic imaging and hormonal assessment for non-functional adenomas and post-treatment cases to monitor recurrence or progression. Special considerations. Genetic testing for patients with family history or features suggestive of hereditary syndromes. Multidisciplinary approach. Endocrinology, radiology, surgery, and oncology teams are essential for optimal care. This structured approach ensures proper evaluation and management of adrenal incidentalomas, minimizing unnecessary interventions while addressing potential malignancy or hormonal dysfunction.